Hello, everyone. We're going to get started. Welcome to the webinar, Moving to Universal ACEs Screening, Findings from a State Advisory Group on Screening Children for Trauma, presented by the National Pediatric Practice Community, or NPPC, which is an initiative of the Center for Youth Wellness. Thank you all so much for joining today. My name is Lena Singh, and I'm the director of the NPPC. We are very excited to share California's journey towards adopting universal ACEs screening today, presenting the origins and the process of the AB 340 advisory group, how this group's recommendations were developed, and providing an in-depth overview of the two screening tools that have been endorsed by this work group. We know that sharing this journey and how we got here will be interesting for providers both in California and across the country as this work unfolds. This is who you'll be hearing from today. We have Dr. Sarah Marks and Dr. Jonathan Goldfinger from the Center for Youth Wellness, Dr. Dana Long from UCSF Benioff Children's Hospital, Oakland, Dr. Neeta Thakur from UCSF School of Medicine, and Dr. Ariane Marie Mitchell from Loma Linda University. On behalf of the National Pediatric Practice Community, it is my absolute pleasure to thank and welcome all of our amazing speakers today. A few housekeeping items before we get started. Today's webinar is scheduled for an hour and a half, and we hope to have plenty of time at the end for your questions. The webinar is being recorded and will be made available afterwards. All of the participants will be muted throughout the presentation. And during the question and answer period, please look to the top left or in a pop-up box for the chat function. This feature enables you to either chat with the panelists or with everyone on the webinar. And during the presentation, we encourage you to dialogue with each other and ask questions via the chat function. And of course, any questions the presenters cannot get to will be addressed in follow-up communications. I'd also like to share a bit about the National Pediatric Practice Community, or the NPPC, which is a network of over 900 medical providers worldwide who are leaders in advancing clinical practice around ACEs and toxic stress. Through this network, we provide online tools and resources to support ACEs screening in pediatric practice, training and technical assistance around screening implementation, and we support peer exchange and learning within the network through consultations, office hours, webinars, and convenings. For those of you that are not members of this network, we encourage you to learn more about integrated ACEs screening in practice and gain access to our offerings by joining this network. Please visit our website, nppcaces.org, and click Join to enroll. And with that, it is my pleasure to introduce our first speaker, Dr. Sarah Marks, who is the Director of Strategic Initiatives at the Center for Youth Wellness and a member of the AB 340 Advisory Group.
Hi there. Thanks, Lena. And thank you all for joining us today. I'm really excited to play my role in this webinar, which is to present the recommendations of the advisory group, and more importantly, the journey that got us to those recommendations. Next slide, please. So here is a brief overview of the timeline. The legislation that we're referring to is Assembly Bill 340. That was passed in 2017. It was authored by Assembly Member Rambula and sponsored by Californians for Safety and Justice. This was not the first time that the state had explored legislation to mandate or support ACEs screening or trauma screening, as it's named in this legislation. But it's the first time that it passed. And so the intent of the bill was really to require that screening services provided under the Early and Periodic Screening, Diagnosis, and Treatment Program, EPSDT, which is part of Medicaid, include screening for trauma. Because the previous bill with a similar intent had been vetoed, this bill sought to establish a multidisciplinary advisory group to develop recommendations for implementation by the California Department of Healthcare Services. In 2018, Per the legislation, the Department of Healthcare Services convened an advisory group. We convened 4 times over the year with some smaller group meetings to set agendas in between those times. And in January of 2019, the recommendations that were developed by that advisory group were submitted to the legislator and to the Department of Healthcare Services. It was right around the same time that we got a new governor, and that governor has prioritized child health and child services. And he submitted a proposed budget that also included dollars for screening, both for adults and children. On February 25th, AB 340 recommendations were presented to the Assembly Budget Subcommittee on Health at a hearing, which was also part of the requirement of the bill. Next slide, please. So this advisory group's primary task was to update, amend, or develop, if appropriate, tools or protocols for the screening of children for trauma within the EPSVT benefit. And there were 2 additional components of the bill that were important. First, that this advisory group was going to report its findings and recommendations to the Department of Healthcare Services, as well as the legislators' Budget Subcommittee on Health and Human Services, and that those findings or recommendations would only be implemented if the appropriations were made, so if there was funding available for them. So next slide. So we got started by convening a group. As I mentioned, it was a multidisciplinary group of folks convened by the Department of Healthcare Services. I was one of the members, and as well as Dr. Ariane Marie Mitchell and Dana Long, who you'll hear from in a little while, alongside 20 or so other folks who represented county behavioral health and social services and public health, medical, mental, and behavioral health providers, experts in childhood trauma and ACEs, child welfare, child health advocates, and then representation from the author and sponsor, and representation from the Department of Healthcare Services and the Department of Social Services at the state level. So it was a pretty robust group of people, bringing a lot of different perspective to the conversation. Next slide, please. Our work started by exploring answers to some critical questions. So while we knew that the legislation had told us that we had to look at trauma screening, we knew that the interest was in screening children, and that the implementation had to occur within the healthcare system, we had some open questions. So first of all, what does trauma screening mean? The legislation's definition of trauma was that trauma is the result of an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being, which is a great definition, but it doesn't tell us what to include in a screening instrument. And so we had substantial conversation about that, and I'll show you in the next slide where we landed, but that was an important component of our conversation. We needed to also, oops, sorry, can you go back a slide? I'm not ready yet. Thank you. Okay. So we also needed to look at whether we were talking about exposures or symptoms. So when we think about exposures, we're thinking about things like abuse and neglect. When we're thinking about symptoms, we're thinking about things like whether kids were exhibiting the signs of anxiety or depression or perhaps behavioral issues. Ultimately, we decided that the purpose of screening was to cast a wide net so we could identify kids who were at risk but might not yet be exhibiting symptoms. However, we needed to also be able to identify whether symptoms were present so that the kids who were already manifesting issues as a result of their experiences could be identified and connected to services, because we were not assuming that all those kids were already identified. And then ultimately, And then in further discussions, we realized that there was also, sort of given the multidisciplinary nature of the group, that there was not one definition of screening or understanding of screening and assessment. And so we dug into that a little bit. We reviewed a bunch of existing screening tools that were used by the state. The CANS, for example, had been rolled out through the behavioral health system. There is an existing tool called the Staying Healthy Assessment, which is used by Medicaid providers. And so we looked at those to see if they would meet the need, and we determined that they didn't at this time. And then we looked at some other existing tools. And then we had some discussion about other critical considerations for implementation. So understanding that the screening tool itself is one piece of this puzzle, but what does it take to make this this screening program sustainable in practice and impactful is really what the group cared about. Next slide. So here you can see the core of where we landed. And so our discussions yielded these recommendations. It was determined that in order to establish a systematic way to identify children experiencing or at risk of experiencing negative consequences from exposures to events that are traumatic within the Medi-Cal program and through pediatric primary care, the tool had to be acceptable by the patient or the caregiver, feasible for provider use, and evidence-informed. So the domains identified as critical were those linked to trauma, and those that linked trauma and negative social, emotional, and physical health outcomes, both during childhood and later on in life, over the life course. And while we knew that the list of possible exposures were very long, we tried to list them out, and we had several discussions about what exposures could lead to these outcomes. We really came back around to focusing on where the evidence was. And that led us to the Adverse Childhood Experiences Study categories. You can see this image here is probably one that many of you have seen before. Basically, the summary of that is that we were looking at categories that fit within child abuse, child neglect, and household dysfunction. And then we explored some other categories, social determinants of health, and other potentially traumatic events that have also been linked to negative health outcomes. Those include major stressful events, community violence, discrimination, and poverty. Next slide, please. So building from that, we had started to review tools prior to coming up with the criteria. Then we decided we needed the criteria, and so we came back to reviewing tools after we had that criteria established. And so we were looking for brief self-report tools that screen for ACEs across all pediatric age groups. And we selected these tools based on a literature review. Several folks within the advisory group had conducted literature reviews in the past. We relied on that information, and we looked at new information as well. And we really looked closely at the Center for Youth Wellness ACEs questionnaire, the BARC tool, which was later renamed the PEARLS tool. You'll hear about that in a little while. The Whole Child Assessment, which you'll also hear about, the Childhood Trust Event Survey, the Yale Vermont Adversity in Childhood Scale, and the Montefiore Clinical ACEs questionnaire. None of these tools had published data to distinguish validity or reliability, but the PEARLS tool and the Whole Child Assessment were the two that had been used by pediatric practices in California and had very supportive preliminary data. Next slide. So that's how we came to the recommendations. The recommendations state that that the state should consider using the PEARLS tool, the Whole Child Assessment tool, and then we added a third category, acknowledging that some providers may already be screening and find their tool appropriate, or that the field is advancing. And so we said, if a tool meets the basic requirements that we outlined, those criteria that I mentioned, that there should be a request process in which they could designate an alternative. Next slide. So to give you just a quick snapshot, and we're going to hear a lot more about these two tools in a moment, I want to sort of put side by side these two tools, the PEARLS tool and the whole child assessment. Key distinguishing factors between the two tools. The PEARLS tool is really designed as a focused tool to screen for exposure to adversity as part of well child care, where the whole child assessment is a more comprehensive tool. It has adversity embedded into a broader assessment. They address many of the same ACEs and other stressors. Some distinguishing items, PEARLS includes discrimination, whereas whole child assessment includes acute stressors. The whole child assessment has some symptoms of trauma embedded in the bigger tool. PEARLS does not have a symptom checklist attached to the tool, but a sister symptom checklist is under development currently. They both address multiple age groups and include both caregiver report and self-report versions. Next slide. Okay, so I did briefly mention that we had additional considerations, and it wasn't within the scope of this advisory group to dig into these. It was deemed that the focus was really on giving recommendations on what trauma screening could look like. But we did surface some considerations for the department to support a successful implementation process, and that includes training for medical providers or the healthcare team around ACEs. It's a slightly different language. Not all providers have experience with trauma screening or ACEs screening. And so that component is really important to make sure that the clinics are prepared for this. But we didn't dig into what that should look like or how that should happen. That was not part of our conversation at the time. Intervention and referral services for needed to be aligned to the screening. That's another long conversation perhaps, or conversation that needs to be addressed. You know, what services does a screening open or help families connect to? Again, that was mentioned but not dug into. Coding and tracking. How do we know that providers are actually screening? We recommended a coding mechanism, and the department has actually gone ahead and identified a CPT code so that they can do that. And then ACEs as an intergenerational concern. So while the group largely supported the idea of screening in pediatric primary care and looking at ACEs during childhood, we all acknowledge that ACEs are intergenerational and affect us over the life course. The governor went ahead and in his proposal included screening for ACEs both in adults and in pediatrics as a acknowledgement of the same concern. Next slide. So that wraps up sort of the process and the summary of how we developed the recommendations through the AB 340 advisory group. The recommendations have been submitted to the legislator and to the Department of Healthcare Services, and a lot of work is going on now to figure out how that all gets implemented. A few upcoming events is probably more relevant to our listeners who are in California, but for those who are tracking the process, it might be interesting to hear that the advocacy and efforts around creating a bigger support system to get us towards a universal ACEs screening is ongoing. So today there is a hearing on AB 741, Assembly Bill 741, which is a trailer bill to AB 340 that includes this idea of training for providers in trauma screening. On April 25th, so just in a few days, the AB 340 recommendations and the ACEs screening proposals will be heard in front of the state Senate. And on May 1st, for those who are in California and want to come do some policymaker education, you're welcome. We're going to be having conversations with our legislators around issues that address or policies that could help us address ACEs and childhood adversity in the state, including but not limited to this issue around ACEs screening. This event is hosted by the California Campaign to Counter Childhood Adversity, or 4CA, which is a multi-sector policy advocacy group, of which Center for Youth Wellness is a member. And that's it. That wraps up my section. I'm happy to pass it back to you, Lena. Thank you so much.
Thank you, Sarah, for that overview of the AB 340 advisory group and its recommendations. And now that we've heard a summary of that advisory group's findings, let's move on to an overview of one of the tools that's been recommended by this group. So it's my pleasure to welcome the principal investigators from the Bay Area Research Consortium on Toxic Stress and Health, or BARC, Dr. Jonathan Goldfinger, Dr. Dana Long, and Dr. Neeta Thakur. BARC is a partnership between the Center for Youth Wellness, UCSF Benioff Children's Hospital, Oakland, and UCSF School of Medicine. Dr. Jonathan Goldfinger is a pediatrician with expertise in team-based care and clinical innovation, and he currently serves as Chief Medical Officer and Vice President of Innovation at the Center for Youth Wellness. Dr. Dana Long is a pediatrician with a career in community-based peds. She's the Director of Clinical Transformation for the Child Health Equity Institute and Medical Director for the Department of Community Health and Engagement, UCSF Benioff Children's Hospital, Oakland. And Dr. Neeta Thakur is a pulmonologist and assistant professor of medicine at UCSF School of Medicine, who has expertise in biomarkers and asthma. This group will be discussing the Pediatric ACEs and Related Life Events Screener, or PEARLS, and I will now turn it over to them.
Thanks, Lena, and thank you everyone who put this webinar together and everyone who joined. We're so thrilled today to be able to share with you the PEARLS and to have Ariane share with you the whole child assessment, particularly because and I'm sure we may all have our reasons. From my point of view, we're living in really a watershed time where not only is the recognition of the importance of childhood adversity and trauma at the forefront of the public's eye, it's also at the forefront of pediatric care and health care, both for children and adults. It's at the forefront of what our state is looking at, as Sarah so adeptly described. And it really, in my opinion, is the leading edge, if you will, or the vanguard, perhaps, for how pediatrics can almost reflexively look back at everything we screen for or ought to be screening for, and perhaps could do better at. And I'll say that to say that the context in which screening for ACEs, adverse childhood experiences, and early adversities or childhood adversity that we find ourselves in is not 100% exactly where things have always been. For those of you who've been kind of keeping score with regard to screening, for a long time, the American Academy of Pediatrics has recommended screening for child development at roughly the same ages as we are going to recommend screening in the state of California. Will recommend screening for childhood adversity, and yet it's taken many years, probably over 40 years by most estimates, to increase child developmental screening rates in the early years from roughly about a fifth of providers, if you ask providers, to now a majority of providers. What's interesting is in surveys of parents, the National Survey of Children's Health, parents reflect that only a minority of providers have been screening them. So this indicates, even today, a discrepancy in terms of what is screening and how do parents experience screening and how important that really is. One of the ways to interpret this is that the providers, 60% or more of which who say they're screening for childhood development, are probably actually doing more in terms of surveillance. It's probably preaching to this choir who've joined today that surveillance is mostly what many of us were taught to do, and what many pediatricians think they're doing screening, but they're actually doing surveillance, in that we were trained to ask, do you have any concerns today about your child's development, growth, and hopefully one day we'll come to asking well-being. However, that's not sufficient. We know from most of the research out there that by and large, providers are just not as sensitive or specific when it comes to identifying children with early needs in terms of development. And so the same idea, the same concept invariably would hold true with regard to childhood adversity and trauma, which is a relatively new thing or a new field in pediatrics, although the literature on this importance of the adverse childhood experiences we all probably know goes back to the late 90s. So it's really important that we think of screening for ACEs and additional adversities in that context, because we have an opportunity here with the PEARLS and the whole child assessment to really accelerate how we screen and even the fact that providers ought to be screening. In fact, in one study, just to give you an additional piece of context about developmental screening, run by the AAP, practices that received support actually found that even if they were doing surveillance, let's translate it here, even if they were asking parents, has anything scary or traumatic or emotionally difficult and upsetting happened to your child recently, even if we had such a surveillance question that we were to ask, in the developmental context or the parallel, providers found even when they asked such a thing, they invariably in their workflow struggled to then implement screening if that question was a yes from a parent. And so we set out the Bay Area Research Consortium on Toxic Stress and Health, my colleagues who you'll hear from in a bit, along with Nadine Burke-Harris, whose role as one of the PIs for the BARC I was fortunate to be granted upon her transition to now being the new Surgeon General of the state of California. These groups set out to understand, okay, if we actually need a screening tool, what can we do to advance that science and practice? Next slide, please. So as was mentioned, these are the partners involved: CYW, UCSF, Benioff, the Children's Hospital in Oakland, as well as the School of Medicine, represented by myself, Dana Long, and Nita Thakur, who are speaking to you and sharing this today. The goals, as I mentioned, were to create a true validated screening tool that a pediatric practitioner could use in a well child visit to identify that adversity had occurred, and a broader sense of adversity, not just the original ACEs, but additional adversities, as you'll see on the PEARLS, and what some people would refer to as social determinants of health as early as birth and infancy. To also look at those adversities in the context of how they are associated with health outcomes and any other signs, particularly early signs of the biologic dysregulation we now know and describe as toxic stress. To really see what could a provider do in real time, not just to know that something has happened to a child, but assess, is there a physiologic change? And you'll hear more about that. As well as to understand how might we actually develop and test different interventions with an ACEs and toxic stress lens. What might we say and do differently, both for the behavior change that we think might be needed, to the preventive, nurturing care, the buffering care to prevent toxic stress, as well as physiologic intervention. That's really where I think the future of this field is going now that we're really making headway in terms of screening for ACEs. And we would be remiss if we didn't dramatically thank our funder, the Tara Health Foundation, without whose support we really wouldn't be here today sharing with you this incredible tool we've developed. With that, I'll hand it off to my colleague, Dana Long, to take you through how we did that.
Thank you, Jonathan, for that wonderful setup to talk more about how we actually went about creating the tool and how we integrate it into our clinical flows. I just want to give my gratitude and appreciation to all of you on the phone. This work on transforming pediatric care is truly inspirational, and the collaboration with the Center for Youth Wellness has certainly been a highlight of my work life. We started to work together in about 2013-14 to start to think, how can we actually create a prospective pediatric ACEs screening tool that combines both the traditional ACEs as well as determinants of health that can be used in a prospective manner in order to risk stratify children so that we can identify children early on and provide interventions to mitigate the effects of toxic stress. We actually did 4 pilots, of which I'm going to highlight 2 of them today. One of our pilots was called FIT, which stands for the feasibility of implementing tools. The purpose of this pilot was to create a tool that we could then generate evidence around in a randomized controlled trial in order to do face and statistical validation that we then correlate with biomarkers and symptomatology and then follow kids over time. The process of creating our tool really involved multidisciplinary work group meetings that included physicians and nurse practitioners, mental health professionals, community health workers, early intervention specialists. We met one-on-one with families as we had a ton of agility when we piloted these questions. We did a deep dive into the literature. We contacted experts and key informants to identify relevant ACEs and trauma questions. We then took all of these questionnaires and created a huge spreadsheet, which separated the question by intention and category. We modified the questions so they were culturally humble and relevant to our patient populations. And ultimately, we created the first draft of Pearls, which includes the 10 original questions and 7 more questions for a total of 17 questions. Each question on the survey has a strong evidence base for a dose-dependent association with negative health outcomes. And then we looked more intentionally at each of the initial domains of abuse, neglect, and household dysfunction. For the abusive questions, we looked at emotional abuse and then expanded it to include emotional neglect as well. We looked at the item that included incarceration and really broadened it to add other forms of separation from caregivers, such as from foster care or immigration or death of a caregiver. The original item about divorce was broadened to really assess family cohesion, with the acknowledgement that many of our families live together and cohabitate and are not officially married. Within the domain of household dysfunction, we added questions about caregivers that have serious physical illness or disability. And then we added a 4th domain, and this was super important to us because it was reinforced by the growing literature that really supports that issues of determinants of health can actually cause the same type of biologic dysregulation in our endocrine systems, our metabolic systems, in terms of our mental health and our physical health. So those 4 domains within the 4th domain, we added 4 questions for food insecurity, housing instability, discrimination and bullying, and then violence outside of the home in the community. We also made some other smaller changes that we felt would have a huge impact. We took out pronouns from the survey, so there's no he or she, but your child or your. And we expanded the caregiver mental health item. What we realized when we were piloting the questions with our families is that oftentimes our families don't think about mental health in the same way that we do as clinicians. And so we added examples. So are you concerned about a caregiver's mental health, including depression and anxiety? And then we also added the word jail to the incarceration item. So all of this created a tool that we now call Pearls that even though there are 17 questions, we like to score it such as there's the 10 original and then the 7 extra questions. Next slide. We also added three other surveys, and those 3 other surveys were based upon the age group of our child. And so for the randomized controlled trial and our piloting previous to it, we really focused on the younger children, the 0 to 11-year-olds up to the 12-year-old birthday. And then we wanted to make sure that we had a tool that was inclusive of our teens. And so there are 2 tools for teens. The first one is for teenagers that are between the ages of 12 to 19. That's actually filled out by the caregiver for the teen. And then there's a teen self-report tool. And I'm going to go into what these added 2 questions are in a minute. I had referenced the fact that we did 4 pilots, and I was going to talk about 2 of them. The other pilot that we felt was really important to get a better grasp of understanding on is this conversation about, do we actually administer an identified versus a de-identified tool? And so we decided to test it out. We asked families and we asked our providers, what is your preference? What do you prefer? And then we had our families take both versions, identified and de-identified. And what we found amongst our families is that 92% of them preferred to take an identified screen. What they reported to us is that if I'm going to take the time to fill out this survey, I want you to do something about it. I want you to know what's happening in my life because these are real issues, and how are you going to know how to assist me if you don't actually know what the issue is? What we found from our providers is that several of our providers also said that they preferred the identified version, but ultimately wanted the decision of leaving it identified or de-identified up to the patient. They felt that if they actually had the identified tool administered in their clinic, they wanted to make sure they had the resources available in order to address the issues. Next slide. So on this slide, you're going to see the 2 additional items that we added. And these items are, there's a version for the teenage self-report and the caregiver report. And the questions are, have you ever been detained, arrested, or incarcerated? And have you experienced verbal or physical abuse or threats from a romantic partner, such as a boyfriend or girlfriend? And then for the caregiver, the questions are for the teen version, has your child ever been detained, arrested, or incarcerated? And has your child ever experienced verbal or physical abuse or threats from a romantic partner? Next question. So ultimately, this is our PEARLS tool. You can see that there's 2 sections. There's the initial 10 sections on the first page, and then the additional 7 questions on the next page. It's really important for folks who are listening to recognize that this is an adversity and social determinants of health tool. This tool addresses trauma, and it's really important to ask these questions in combination with questions that focus on resiliency and protective factors, because we know that trauma is buffered by resiliency, by having safe, stable places and relationships with caregivers. Next slide. So how do we actually do this, right? How do we actually use this tool in real life, especially for those of us that work in very busy clinics? So as Jonathan mentioned, I'm a primary care provider. I work within a federally qualified health center. We are an extraordinarily busy clinic, and over 90% of our families have Medicaid, and 90% of our families are also families of color. What is the workflow? So you can see when it talks about process, this is a very generic workflow that our hope is that you adapt it to your sites, right? So the overall process is that we administer the tool gets scored, that the results get documented in the EMR, that we assess for symptoms, we determine follow-up, and then we provide referrals and community linkages. An example of what this could look like is that it could be a frontline staff member who hands the tool to the caregiver, asks the caregiver to please fill it out. The medical assistant then rooms the families, they put the results in the EMR, they collect the tool, and they loop back with the medical provider to let them know what the score is and what the questions are that are endorsed. Then we, as medical providers, we do our well-child check. We provide anticipatory guidance, and then refer to a care coordinator or a behavioral health specialist in order to provide the referrals and follow up with the family, being mindful that we follow our standard of care if there are any incidences that come up in the visit that suggest that a CPS referral needs to get made. Next slide. So this is an example of my team, and I wanted to walk through this example with you because we have to always walk the walk and talk the talk and know what it looks like on the ground. And so if you look to my left, you'll see this is our community health worker, myself, my truly amazing 7-year-old patient, her mom, our mental health specialist, and then our volunteer. So in our clinic, our community health worker will, when families are getting roomed, they will approach the family and they'll say, This survey asked about different social stressors that could be affecting your child's health, either now or later on. We have resources available at this clinic that we could connect you to, such as food and housing, mental health resources. Would you mind taking this survey for your provider? Families are always given the ability to opt out because we want to support families to be the heroes in their own life and be able to control the situation and the agenda that's happening. If a family opts out of taking the tool, then we still provide the anticipatory guidance and the resources to the family. If the family takes the tool, then the community health worker then collects the tool, puts it on the door so that when the provider walks in, they can look at the tool. Every single patient gets anticipatory guidance about the effects of toxic stress and resiliency. We give out the AAP, Connected Family, Connected Kids cards. And if the score is 1 or more, the provider will contact the community health worker who will then provide resources if it's a food and housing issue and ask about other basic needs. If the score is 1 or more and there is also an issue of trauma and adversity, that family will get referred to our behavioral health team, who then will go into the room, do more assessment, and then connect the family to further resources. This is one example, and I'm happy to share our flow out when we hand out when the recording is given to on the MPP website. But I also want you to know that the Center for Youth Wellness also has a flow, and I'm going to pass it back to Jonathan.
Thanks, Dana. So to Dana's point, it does take a village, a whole team across the practice and the family, parents and the caregivers, and even community members to support children who've experienced that adversity and certainly to prevent it. My goal in sharing here with you the screening and scoring algorithm is less to say who, but how do we use these screening results to risk stratify. And the reason we're sharing the CYW algorithm with you today is that the PEARLS is currently being analyzed for the similar associations, which you'll hear about in a bit, and hopefully biological markers of toxic stress that would really refine, we hope, the type of risk stratification and scoring algorithms possible to date. So we haven't created the PEARLS scoring algorithm, but we believe, I believe I speak for the other PIs and myself, that it will go something like this. In general, a child with a score of a 0, whether in the first section or the second section, or actually would need to be both, in both sections would be considered low risk, especially if that child has no symptoms or health problems attributable to ACEs. We want to be very clear that when this diagram or this algorithm describes the problem, we're referring to problems or symptoms that can be tied to trauma. And that's part of the work we're doing at CYW to develop that companion symptom checklist. So providers and even parents can kind of check whether or not a child is manifesting symptoms shown in the literature to be associated with ACEs and toxic stress. And I believe if you're using ACEs screening in your practice, you probably have already had the sense that there's additional symptoms and health outcomes or problems that are really not fully fleshed out. So I believe that we're going to identify those further. So real quickly, if a child in either section has between a 1 and a 3, we consider that an intermediate risk, and 1 and a 3 plus symptoms, or a 4 plus regardless of symptoms or attributable health problems or disease, a high risk. And so the reason we risk stratify this way is both to determine how to utilize resources. We all know that healthcare resources aren't infinite, unfortunately, especially with regard to serving children and families. So we want to make sure that we are really targeting the children who need something with what they need in a timely manner. And so we have always felt that all families deserve and would do well to understand through patient education, anticipatory guidance, what are ACEs and toxic stress. As with other forms of screening, the PEARLS is a perfect opportunity to develop that relationship. As was noted, parents appreciate it, so you can actually use it as an opportunity to discuss adversity and toxic stress to prime parents in case something like that were to happen. Hopefully they come back and share it with you without even having to screen. But even if there's a 0, you're likely to screen more times when you're screening for ACEs and childhood adversities. The state of California is recommending even every year in children to potentially screen. And so when you're doing this for children and families, as Dana mentioned, all should get that education about what we're talking about, but especially those with any symptoms. We really should be thinking about how do we build up their protective factors, their resilience. And I say build up because we want to make sure that we're also coming from a strengths-based approach, recognizing that all children and all families have inherent strengths and are not just those coming to our office with a deficit. And in fact, that those strengths, those connections they have between them, between the parent and child, the dyad, or even with their communities, are inherent things we can build upon to help protect a child who may have experienced ACEs or may further experience ACEs. And in children in the intermediate risk, we kind of at CYW say it's optional based on what's needed to connect the family. If the provider feels they need further parenting support, referrals, etc. We know from the history of developmental screening, again, that invariably we invest in the screening, and then what gets dropped off with regard to referrals. So it's really important to have in place already, as we do at CYW, a system to basically note for everyone in the practice, what are we doing? Some would refer to that as a protocol, right? What do we do in the case of this specific adversity or this score? And so while in the 1 to 3 category, because there's no obvious symptoms yet, those may be optional. Obviously, as was described, if a child or family is showing signs of maltreatment, we absolutely have to move forward with the appropriate standard procedures to get Child Protective Services involved if our assessment shows a real risk to that child. And then for everyone, we would follow up with medical appointments as necessary. For the high-risk children, as you can imagine, I don't think it has to be overstated. What you're seeing here is all of the above, right? The patient education, the focus on the symptoms and the health problems as well with the parent, and helping them to identify that something scary may actually be the trigger for their asthma. And then may want to really focus on the mindfulness, the buffering of the toxic stress in a child having an acute attack of some childhood chronic disease or disabling disease or behavior. And so really important to bring all of that, including trauma-informed therapies and other services in the community and other treatment modalities that have been shown to reduce toxic stress and other stressors and really buffer children and help them build further resilience. And with that, I'll take further into how we're hoping to advance the science through the PEARLS and the RCTs we've been working on with Nita Thacker.
Hi, thank you, John and Dana, for setting up the tool so well and describing on how it was developed and how it can be integrated into current workflows and practice. I'm going to shift us a bit and talk about our current study, the PEARLS research that we're conducting at Benioff Children's Hospital, Oakland, in partnership with CYW. We will talk about some of the current results from the PEARLS study and our next steps with PEARLS, and to also highlight areas for potential partnership with the larger California and national community of practitioners, including those of you that are on the call today or the webinar today about potential ways that we could partner together to better understand the way ACEs impact health and what we can do to mitigate those impacts. And so first I'll be talking about ACEs and future health risk using our current study, and then our hope to use statewide data to look at that a little bit deeper. I'll also be talking about the framework that we've been using to think about how ACEs really get under the skin and contribute to poor health outcomes by affecting different biological systems. And hoping from that work, we can start thinking about biomarkers of stress and see if that, in combination with a risk tool such as the PEARLS tool, can help us develop a pediatric risk assessment tool to help identify at-risk children. And we're doing some of that work in our current PEARLS study, but this is also an excellent way to think about partnerships across the state or maybe even nationally about participating in future research with us on how to validate these risk assessment tools. Next slide, please. So in our current PEARL study at Benny Hoff Children's Hospital, Oakland, we have recruited 555 kids where we have screened them for ACEs using the PEARLS tool that was described earlier. And of those that we've screened, at least 80% of them have endorsed at least one adversity. And if you recall, this is adding an additional 7 questions around adversity that includes some social determinants of health. And if you were to limit those findings to the 10 original ACEs, almost 70% of the group endorses at least one ACE. What we also see in our population is that 45% of our patient population have 4 or more ACEs. And of the 10 original ACEs, 22% endorse 4 or more ACEs. And what we've seen in our study population, which has a median age of 5.5 years, is that we're already starting to see associations with childhood asthma, obesity, and reports of missed school days in our group. We also see that ACEs in our study population are associated with poor self-reports of health and also increased caregiver perceived stress. So showing that we are starting to make connections with ACEs with some important pediatric health outcomes, and also that we're starting to see this early in life. Next slide, please. And when we're starting to think about how ACEs might be impacting health, I think it's helpful to take a step back and think about the framework we're using to think about how adverse childhood experiences are getting under the skin and contributing to poor health outcomes. So I wanted to just briefly take a moment to talk about the toxic stress framework. And I think most of us know that experiences of positive stress are important for our own well-being and also for evolutionary development. And this is sort of what we experience in giving a talk or in brief situations of stress. There are times where we have increased stress, which is considered tolerable stress. And I akin this to our experience in residency, where we are in a constant state of stress, but they're being buffered by supportive relationships. And this aspect of being buffered by supportive relationship is really important. And this is also where the role of resiliency is helpful in trying to mitigate some of the experiences of stress that people may be experiencing. And it's the absence of these buffered relationships and this prolonged experiences of stress that causes this toxic stress response to occur. And this can affect your biology in several different ways. Next slide, please. And the 3 main categories of biological responses that we've seen are across the neurohormonal and inflammatory system. This is also called the allostatic load framework that was first described in 1998, where the wear and tear on the biological system leads to a resetting of our biological response across many different human systems. And that resetting causes a chronic inflammation and chronic changes in our neurohormonal response that later increase your risk for disease. The second is more of the genetics and how does your genetics interact with the environment. And this includes gene by environment interactions. This is epigenetics, so thinking about telomere length or methylation, which have been getting a lot more press lately. And then also changes in the microbiome, where you're seeing changes that occur in the presence of chronic stress. And then lastly is neuroplasticity, where there's been studies that have demonstrated that chronic stress actually shrinks the brain networks, especially in the absence of buffered relationships. Next slide, please. For our PEARL study, we're focusing on these first 2 categories, so the allostatic load and also looking at genetic factors that may interact with stress or changes that occur through epigenetic phenomenon and in the microbiome as related to ACEs. And what we're hoping from this work is to develop a profile or of stress response that we see in association with ACEs. In our next slide, you'll see that we're hoping to use this information in combination with our PEARLS tool. And the PEARLS tool and other screening tools are really great in that it helps us identify and potentially direct resources towards those that are deemed to be at risk. But one of the things that we're interested in knowing, especially in those children that may have one ACE or a couple of ACEs, is really who's at high risk and how can we get to kids earlier than when disease outcomes that we are trying to prevent haven't occurred yet. So next slide. And so we're hoping these biomarker profiles in combination with a risk screening tool can help us really identify those who have high toxic stress against those that have low toxic stress and see which individuals would truly benefit from having resources earlier in their lives in order to prevent poor health outcomes. And this can be especially useful in helping target resources in a low resource setting. It could also help us decide who may need a higher or lower intensity of intervention. And with that, I'll bring it back to Lena to introduce the second tool that is going to be part of this webinar for screening for ACEs.
Thank you, Neetha. And thank you, Dr. Long and Dr. Goldfinger and Dr. Tucker for giving us an overview of PEARLS and how it was developed through the BARC partnership. It's now my pleasure to introduce our next speaker, Dr. Ariane Marie Mitchell from Loma Linda University. Dr. Marie Mitchell is an assistant professor of preventive medicine at Loma Linda University School of Medicine and assistant professor at Loma Linda School of Public Health. She has a career in pediatrics and has been working on addressing ACEs in peds since she began her medical training in upstate New York. And I'll now turn it over to her to address one of the tools that has been recommended, the Whole Child Assessment, or the WCA.
Thank you, Lena. I want to start off by expressing my gratitude to NPPC for hosting this webinar today, and also to the Pediatrics Department at Loma Linda for supporting the work on the Whole Child Assessment. The PEARLS is a great example of a trauma-specific tool. The Whole Child Assessment is an example of an integrated tool. It screens for exposure to trauma, but also for risk for trauma exposure. The Whole Child Assessment is particularly useful if you're listening to this call, you're wanting to start screening, but you're feeling overwhelmed as how do you add yet another topic to everything else that you're supposed to cover in a very short amount of time. So let me share with you a little bit about how we developed the Whole Child Assessment. Next slide. I actually started this work when I was in upstate New York. I had funds to do some pilot work from the Academic Pediatric Association, and we surveyed parents of children aged 4 and 5 years old that were coming to our clinic, and we found that responses to just 6 or 7 questions were associated with higher risk of behavior problems, language delay, and higher risk of injury visits. The other thing to note, though, about that study is that it was done as a research study, meaning that it wasn't part of our pediatric practice. It was done in the context of a research visit, and I think research or context makes a big difference in reporting, especially for something sensitive like ACEs. So the next step that we needed to do was to test whether screening for ACEs in a normal pediatric practice, how effective that was. And so we developed a trauma-focused tool. It was called the Child Household Survey. It included those 6 to 7 items and several other ones that we wanted to explore testing. And the challenge was that we had several other questionnaires that we were also supposed to be administering. The clinic that we were working at was serving Medi-Cal patients, and in California, the Staying Healthy Assessment is a required screening tool unless you get approval to use an alternative. We also had to screen for tuberculosis, and we were also following guidelines to screen for adolescent depression. And in addition, we had an initiative to screen for maternal depression. And I left off, because I forgot about it, that we also had another separate patient history form that included interval history, review of systems, and developmental surveillance. And all of those questions, which added, I'm not even sure what they added up to, but well over 50 questions, were on top of whatever questionnaires that families had to fill out at registration. So just from a pure workflow perspective, this was too burdensome. Next slide. So that was really what motivated the desire to come up with an integrated tool so that we could accomplish everything else we were supposed to accomplish at a well child visit, but also include screening for trauma. And so we began this work with parent interviews about the questions we were considering asking, as well as interviews with our residents and our faculty and other professionals, and thereby documented face validity. We also took a second look at the literature to make sure that we were using questions to screen for ACEs that aligned with data on ACEs. And we worked with the Department of California Health Services to get approval for our integrated tool to be an alternative IHEBA, which meant that we wouldn't have to administer the SHAW or Staying Healthy Assessment in addition. And so that was approved. And we then implemented our tool and got rid of all those other questionnaires. And we monitored, in terms of the ACEs questions, we monitored response rates versus what we expected the prevalence rates to be. We started screening with the integrated tool in October 2016, and our last examination of data showed that we were getting about 19% of families were reporting 2 or more ACEs, and that's comparable to the rate we would expect based on kids' data for the same area. Next slide. So we currently have 9 forms that are age specific, go from age 0 to 20, and we have all of these forms in English as well as in Spanish. And the trauma screening questions are the same for the age 1 to 11 years old, but the trauma screening questions for the infants and then the older age group vary a little bit by age there. So, you know, the forms have in total about 30 to 50 questions, which I don't know, that may sound like a lot to you, but from where we started, it is a sizable reduction in both number of questions, and then the workflow is a lot simpler because now we're predominantly using one form. The only addition, as John was mentioning earlier, is the need to screen periodically for development. So that's the only separate form that we're using. So, and there's a lot that is embedded. This is what we're currently doing is all on paper. But we are working toward integrating our tool into our electronic health record, which will allow families the option of completing the questionnaire at home before the clinic visit. Next slide. So this is an example of what a complete one of the questionnaires looks like, sort of complete. You can mostly see it. Most of the English forms are 3 pages in length, and the Spanish forms are mostly 4 pages in length. You can see there's a fair bit of space on the forms so that families can respond to some of the open-ended questions that we have. And as Sarah indicated earlier, the whole child assessment doesn't just screen for exposure to trauma, but also risk for child maltreatment, which is intentional and is trying to build on the work that Dr. Dubowitz did on the Safe Environment for Every Kid, the SEEK tool. And I think that's just a really important opportunity at a pediatric visit, is to acknowledge that we have an opportunity not just to identify trauma that has already occurred, but in the case of child abuse and maltreatment, to potentially prevent that. And I'd like to point out that the tools also include questions about trauma symptoms, which is helpful to making decisions about management and evaluating how effective the screening is. Next slide. So this gives you a sense of the workflow. Quite simply, when the patient arrives for the well child visit, the front desk hands out a questionnaire. If it's a child age 0 to 11 who's checking in, it's the caregiver who completes the questionnaire, and 12 and above, it's the patient who completes the questionnaire. And then the staff encourage the families to complete the form before the provider comes into the room. Next slide. So this is the workflow perspective of the person who's reviewing the whole child assessment. If there's any concern with ACEs, there's an information handout that we have. I'll show you that in a minute, which summarizes very briefly some important things from a parent's perspective to know about ACEs and resiliency. And our providers are encouraged to document Z codes for any clear histories of ACEs. And then the next big question, though, with this screening is whether this is a current concern, because our questions are a mixture of has this happened in the past, or is this a current problem? And you know, in some cases, if this is a past exposure, but the child is asymptomatic, other than going over the information about ACEs and resiliency, noting the Z codes, there's not necessarily more to do. But if there is a current concern, then go on to what you see listed there as tier 1, 2, and 3. I always stress when I present on the whole child assessment the value of that provider right there doing some brief counseling. And I can't really kind of go into that in more detail, but suffice to say that that's, I think, a really important opportunity that exists in pediatric practice, is to do that brief counseling and support for that parent-child relationship. And then not always, but sometimes, based on what's discussed, there's a need for referral to resources. And I mean, if you're fortunate to have integrated behavioral health, you can do a warm handoff. If not, provide information on how to access some of the resources listed there. And of course, we make sure that our providers are aware of how to deal with safety concerns that may come up, requiring immediate intervention by CPS or crisis response team or law enforcement. But that is definitely more the exception than the rule. Next slide. One nuance to point out about version 2 of the whole child assessment, when you get a chance to look at the forms in detail, I know the slide earlier wasn't easy to see all the questions, but the forms are available on our website. And when you look at it, you'll see that all of the questions start off with the interval history, then tuberculosis, dental, and so forth, and they're listed in that way because that's a very patient-friendly order to answer these questions. But the domains are numbered on the right side of the form to help remind the provider to start off with the interval history, but then flip to the last page of the form and review the safety questions. If there's nothing of concern on safety, review the substance questions, and so forth backwards through the form. And in my experience, this is of tremendous help to make sure that some of the most important topics are covered before that family leaves that day. Next slide. So you notice that the workflow that I presented is not based on a child ACE score. Certainly one could use the whole child assessment, could score it and develop your workflow based on that scoring. But because most of our clinics don't have integrated behavioral health, we purposely didn't develop our workflow based on a score. Nonetheless, all of the version 2 forms have at the bottom a little gray box like you see listed there. The numbers refer to the questions that are being counted as ACEs. This scoring is a little more complex than the Pearls in that it's not just 1 point for each question that adds up. For example, question 1 or 30, a yes to either one of those would count as 1 point. But in my experience, scoring literally takes less than a minute. It's not very hard to do. And I do personally do the scoring myself. I find it useful to include that in the child's assessment and give me a sense of that risk when I'm considering other management issues for them. Next slide. So I mentioned as part of our workflow that whenever one or more of the ACEs are identified or there's some other reason for concern, we have this available in our electronic record. That's the smart text is ACEs in English, or the Spanish one is ACEs SPA, and it's just a very brief summary of important information about ACEs, as well as important information about resilience and what builds resilience. And then next slide. That overview is followed by 2 types of community resources that we've built in. So like the list that you see of like under safety there and relationships and so forth, I call that a static list, and that we made that list. I think we last updated it about 6 months ago, but it's not updated unless we go back to this list and update it. But the QR code that you see there, that's something I'm particularly proud of, because it took a lot of work to establish a partnership between the ACEs Task Force of San Bernardino County, which is our community group that's responding to ACEs in our area, and the United Way 211. And so we have this partnership where they've developed this QR code, and San Bernardino County is huge, and so there's individual QR codes for each part of San Bernardino County, and under each of those information related to screening for ACEs is available. And then at our monthly meetings, which we hold in partnership with the Child Abuse Prevention Council, that list is updated. So that becomes a live current resource, which I think is a nice workaround, and a problem that many clinics struggle with is how to keep our resources updated. So that's one way that we have worked on that. Next slide. So we have hopefully some manuscripts coming out soon. We have one that describes in more detail how we developed the tool and also gives our clinic-based reporting rates. And then we have one that we're working on that describes the associations between the child ACE score and health outcomes. We have shown that having a score of 2 or more is associated with multiple both child clinical problems as well as school problems and higher utilization of healthcare services. And we have, because in parallel, we did a research, sort of a psychometric study looking at this tool, and we're looking at data right now to be able to report on sensitivity and specificity and reliability. And we have some degree of biomarkers as well, which also support that although we have a mixture of trauma exposure and risk for trauma exposure questions, that when you add that up and you get an ACE score of 2 or more, we are showing that we are accurately identifying kids who are experiencing toxic stress. in terms of further work, we kind of like the Pearls, we focused mostly on the 0 to 11 age group tool and those questions. The self-report tools are a little bit different, and by the time the 18 to 20-year-old questions, those are looking a lot more like the adult ACEs questionnaire. And I would like to look in more detail about how those versions are doing in terms of health outcomes. And as I mentioned, we're working on electronic administration. Next slide. So you see my contact information there. What I presented is really an overview. It was hopefully useful to you today about what the whole child assessment is and how to use it. But I'm hoping that we're going to do a more detailed webinar to really guide providers who want to implement this in practice. And we don't have a date for that yet, but if you're interested, feel free to email me and I'll make sure that you're on a list so that I can get the word out when that is scheduled. Thank you.
All right, wonderful. Thank you so much. And here you can see some resources for ACEs screening and intervention. We have the National Pediatric Practice Community, public education campaign run by the Center for Youth Wellness, ACEs Connection Network, the 4CA campaign that Sarah mentioned earlier, that's hosting the Policymaker Education Day, and then the National Traumatic Stress Network. I just want to say on behalf of the NPPC, thank you so much to all of our amazing speakers. Thank you for sharing your time and your work and your expertise with us, and we are very grateful. And I think we are ready to open it up for questions. There have been a lot of questions coming in, a lot of really wonderful questions that folks have been asking and thinking about, responding to. I actually am seeing some questions related to implementation of this legislation at the state level. So there's some questions around communication. When is this going to be communicated to clinics in California? How do we track, various clinics where an individual may be screened? What EMR vendors currently plan to support the different tools? And these are really questions that should be directed to DCHS. They'll be the ones that will be putting out additional communication around implementation at the state level. And I don't know, Sarah, if you have anything else to add to that.
So sorry, I couldn't get off mute. Yes, I will put in the chat box now the email address that folks can direct their questions towards. If it has to do with implementation, they'll get routed to the right place.
Okay, wonderful. There was a really great question that came in around how to address resilience. Is there a tool or other approach that you all have used? And I'm wondering either Dana, Dr. Long, or Dr. Marie Mitchell, if you'd like to tell us how you think about that.
Absolutely. So in the chat box, Dr. Goldsinger made some really great suggestions about different screening tools for resiliency. And so maybe he could address part of this question with me. For our community health workers, whenever families get referred to them as part of our workflow, if there's an unmet basic need concern around food and housing, they also screen everyone for joy. And we are in the process currently of working on a project where, just like we have heat maps for where in our population there's food insecurity or housing instability or concerns about child development, we're in the process of creating heat maps for where our families find joy within their homes, neighborhoods, and schools. We ask every caregiver to tell us something great about their child, and then we document the answer. We ask all children who are verbal, 3 and up, to tell us something great about their caregiver. And then we create action plans as we make referrals and community linkages. And the words of the child and the caregiver are at the top of those action plans. It's actually super powerful to start with these conversations of joy and where do you find happiness, and we do that before we launch into the other portion of our screening.
Should I jump in?
Yes, absolutely.
Okay. Well, I have looked and haven't found a a evidence-based set of tools on resilience questions that would really, to me, fit in a pediatric context. What I mean by that is there are questionnaires on resilience, but having them sort of fit into a pediatric visit where there's something for the provider to do in terms of responding on counseling and referring, that's a little trickier to get at, because a lot of the resilience questionnaires that I'm familiar with are a lot more about internal self-perception and that kind of thing. But I do, when I do the trainings on the whole child assessment, spend probably most of my time actually talking about how to use this tool to build resilience, because I think the opportunity within the pediatric visit is to support that parent-child relationship. And I would argue, as a parent of a teen, that extends across the age spectrum. We focus a lot on parents of young kids, but I think that opportunity is really important across all ages. And I would love to say more, but we don't have time. But that's the gist of it.
Can I just mention one other thing? And in the chat box, we talked about different types of interventions, and we have established resiliency groups that are focused on mindfulness, self-regulation, co-regulation, as well as these six domains of nutrition, exercise, eat, healthy relationships. Those resiliency clinics for families that have attended have been really powerful, and families love those centering tools.
I would just add, to really building upon what Dana and Ariane shared, that, at CYW, when we use the protective factor survey tool, the reason for that is that it actually allows kind of a pre and post way where you can track change over time. And it includes, domains that really speak to resilience and help to build resilience, such as social supports, right? Relationships. So concrete supports as well that we're talking about as well, screening for. But the protective factors, as they were conceived, really, for children involved with child welfare originally, they were kind of for caregivers participating in the child maltreatment prevention or intervention. And so they kind of align nicely, but to the points just shared, there have been no validated, what most would consider evidence-based resilience screening tools for prospective use in pediatric primary care. And I think that's critical research that we still need to embark upon, and would encourage anyone interested in that to contact us, to be in touch, because it's going to take all of us to continue to build upon. This webinar should not just feel like, okay, this is about one tool, two tools, and we're done. I think what you've heard here is there's a lot more that needs to get done in terms of resilience, identifying whether a child has and family members have resilience or protective factors with which to build resilience off of ACEs, as well as what systems are in place for accessing services like mental health and other resources in the community. So I would implore everyone, the fact that you've joined, bless you, and we're so thankful for it. And please make the effort to reach out and say, I'm interested in this area, John. I'm interested in that area you mentioned, Nita or Dana or Ariane, or even the policy work that Sarah and a lot of the MPPC team do, because it's together that we're going to identify the next steps, the next interventions, the next screening that needs to get done. And there's a lot more work to be done given what we know about the sizable impact and the varied impact of adversity on children. So thank you for being here, and thank you. Hopefully your questions are portending that you're going to reach out, and we're going to have more opportunities to collaborate.
Great. Well, I know that there's a lot of questions that have been posed around interventions. So intervention efficacy, parents taking advantage of certain types of intervention supports over others. And I'd really love to open it up and to all of the presenters to sort of talk through how you all think about intervention supports after screening? I know that's a really common question that we hear from a lot of providers, and how you're thinking about the efficacy and the acceptance of different intervention strategies.
So I'll just jump in real quick. At a discussion at the AAP, a National Advisory Board for Screening, there was ongoing debate, I'll say, but growing consensus that screening itself is an intervention. So let's not forget that when we do something new with a family or something that's emotionally resonant, as Nadine found on her book tour and the NPPC finds and CYW's wonderful parent and really societal education campaign called Stress Health, you can visit stresshealth.org, has found, this resonates. This is an issue that touches on almost all of our lives, if not every human life. And so utilize the screening as an opportunity to build that relationship amongst your staff with each other, as well as the staff and the providers with the parents and caregivers, because that's an inherent intervention. And then there's more that we're going to really be researching and I'm hopeful partnering on with regard to additional interventions after screening. Others want to jump in?
I'll just mention briefly that I just finished a literature review to try to look at what can be done in more detail. I completely agree with what was just said about that screening is an intervention in itself, and that there's an opportunity in that brief counseling and that follow-up with that primary care provider. But I think there is also evidence that for when we're seeing kids that are 2, 3, 4 higher ACE scores and they're at risk, ideally we can intervene and change those trajectories, and that might involve a little bit more intensity than that brief counseling and brief community referrals. So I'll have to look it up for you, but the literature review just came out in the American Journal of Preventive Medicine, so you might be interested in that.
Any other presenters have thoughts on that question? Dana, I'm wondering actually if you could share just a little bit about the work that's being done to look at intervention efficacy as part of the study.
Sure. So as we worked with the investigators from the Center for Youth Wellness, our initial goal was to really think about how we're actually going to do the face and statistical validation for this screen, acknowledging that we can't screen without pairing families with interventions. And so for the randomized trial, we have a control group and then these 2 other intervention groups. The care coordination around child and adult mental health development and unmet basic needs, and then the resiliency groups. We are following kids longitudinally, and so at the time of enrollment, they get screened, we collect their biomarkers, and then we're following them for 1 year prospectively. We're also looking back 1 year retrospectively to see how are we able to actually, on a biologic level, mitigate the effects of toxic stress. I do think that this is an area of research, as Jonathan said, that really needs to have a deeper dive. And what, in my opinion, what needs to happen is that we really need to more rigorously look at each of these interventions and see what is the dose-dependent response that helps to prevent biologic disruptions. We do hope to be able to have some data that lets us know which of these interventions was more efficacious for preventing further ACEs development or biologic dysregulation, and that data will be coming out soon.
Thank you, Dana. Well, we are almost at time, and we want to thank you all for joining us today. We really appreciate you being here, and of course to our presenters for sharing their time and expertise. And we can definitely follow up on some of the responses to your questions in communications after the webinar. And of course, there are the resources that were mentioned on the previous slide. If we can go back to that really quickly. So thank you all again for joining, and we hope you have a wonderful rest of your day. And this webinar will be recorded and made available afterwards. Thank you.